Start recording here. All right, now let's try this again. All right. Welcome to class. Today is the second day of our discussion on psychological disorders. Before we can continue here, what in the world is going on? Oh, Lord. Thank you for bearing with me here. All right, in theory, we should be good. I don't know why this is giving me a problem. All right, so we are talking about psychology disorders today. Yeah, gotta love technical difficulties. Exactly. What a pain in the tuchus. Yeah, so we are talking about psychological disorders part 2 today, and we're going to talk about kind of broad categories here and then talking about specific disorders within it. A couple of you have noticed that on your Chapter 14 quiz within Cengage, I don't remember the exact question, but it's something along the lines of this disorder is characterized by brief periods of intense dread or fear, in which the heart rate elevates, things like that. The correct answer is panic disorder. For whatever reason, Cengage has it as, I think, agoraphobia. I mean, that's not agoraphobia. I mean, it's almost definitionally a panic disorder. So I have let Cengage know that that's the wrong answer and told them to go ahead and fix that. I haven't been able to figure out if there's a way for me to fix the answer in there. So if you did put panic disorder, you were right. If it turns out that they're not going to fix it and or that doesn't affect your grade, I'll figure out what to do about that actual quiz. But the right answer was panic disorder. All right, so I'm going to go ahead and pause for a second. Does anybody have any questions about what we talked about last time? All right, I am not seeing any questions. I don't remember if I mentioned last class, and if I did, just bear with me. But your SIEs are now open. So please do go fill those out. They help the university understand what they need to work on. They help me understand what I need to work on. And they're also a critical component of the tenure process, right? And so for junior faculty like myself, we have about a 5-year window wherein we have to build up this kind of rapport of both research and service, but as in addition to teaching. And then after about 5 years, we go in front of what's known as kind of promotion and tenure committee. It may have different names at different universities, but they evaluate my research record, my service record, and then also my teaching record. And these SIEs play a big role in that sort of evaluation, at least on the teaching front. And so, you know, these are really important to my career and other faculty member career, in addition to allowing us to know what we need to work on. So for the benefit of everybody involved, please do go fill those out. All right, we're going to go ahead and push on. If you do have any questions about what we covered last time or anything we are covering today, go ahead and pop that into the Zoom group chat box. But alas, here is your fun fact of the day. In Utah, it's illegal to swear in front of a dead person. I don't know why they care, but there you have it. All right. So we're going to start today talking about anxiety disorders and the host of different anxiety disorders. First is what we're going to call generalized anxiety disorder. And so generalized anxiety disorder, is kind of a severe and persistent anxiety. And so one of the things that's important to think about when we're talking about these psychological disorders is that, in the case of anxiety, merely having anxiety about a situation does not indicate that you have issues with anxiety, right? Part of being human is being anxious or having anxiety about certain situations before a big test, before a big life event, etc. But what constitutes a disorder is that it is severe, pervasive, persistent, and interferes with daily functioning. And so I think the question came up last time of what's the difference between generalized anxiety disorder and I think it was OCD. Um, what's really constituting generalized anxiety disorder is this constant worry over numerous stressors, right? And so, anxiety or OCD can manifest in various ways. You can have various anxieties. But one of the things that really denotes generalized anxiety disorder, or GAD, as it's sometimes referred to in writing, is that you have a source of many different stressors that are causing substantial anxiety. And again, it's not just the anxiety that would be predicted, right? I mean, this whole coronavirus situation is very likely to create anxiety in a lot of people, and that's normal, right? It's appropriate to have certain anxieties about this, but it's when that anxiety starts overpowering you and you can't do anything, you can't, focus even on things that you really enjoy, that it becomes kind of denoted as a psychological disorder. One of the things you may see manifest in people with generalized anxiety disorder is a certain amount of irritability or hostility or even insomnia. Because anxiety is an inherently cognitive state, it's hard for you to actually see what anxiety is, right? You can see compulsions, right, in obsessive compulsive disorder, but you can't really see anxiety. And one of the manifestations of people being anxious is that irritability or hostility. And you can think about this even in your day-to-day life when you've been kind of anxious about things. You may have gotten really irritable or short with people you love or around you. You also may have a hard time sleeping. Anxiety may be keeping you up at night, maybe keeping you from being able to sleep throughout the night. And this sort of symptomatic indication, these physical symptoms associated with that cognitive experience of anxiety, is the constant motor tension. So, right, your constant tension in your muscles, your shakiness, right? You may have as a byproduct of this tension, kind of a shakiness in your hands, your inability to relax, feeling like you're always at 100%, having dry mouth, and also racing heart, etc. Right? So think about what are the symptoms that you may experience in short-term anxiety, right before an exam, and then extrapolating that out to long-term, which would be the case perhaps with generalized anxiety disorder. So you are having these physical manifestations of that cognitive experience. Panic disorder. So we talked a little bit about panic disorder last time and showed that really great example of the newscaster who you could see kind of fall into a panic attack. All right. And so panic disorders are distinctly separate from anxiety disorders, or at least distinctly separate from like generalized anxiety, because the severe anxiety attacks are usually very physical in nature, but they also tend to have no grounding, right? Anxiety itself is something that you usually attribute to some sort of source, right? I'm anxious about the test, I'm anxious about relationships, I'm anxious about driving, etc. However, a panic attack is more just like it's almost like your body is creating this sort of rush, and then you can attribute it to things later, but it may feel like a heart attack. You will have this rapid heartbeat, nausea, tingling, loss of controls, chills or flushes in your skin. And it's a really overpowering sensation, right? If you've ever had an experience of complete dread in your life, maybe it was hearing bad news or something in your life happened, or you were just, you know, scared to death by a movie and you had really physical sensation, that's emblematic of a panic disorder, right? And so these panic attacks can be irregular in frequency, and there are ways that people can deal with it. But the panic attacks don't frequently have something that are attached to them in terms of kind of this temporal correlation, right? It's not obvious to the individual experiencing the panic attack that something caused that panic attack. It just kind of arises, which can create this real fear in people of another attack. So people may isolate because they don't want to be out in public when they have a panic attack. I'm sure a lot of you, if you haven't already, at some point in your life will experience maybe a panic attack. It may just be a singular one, but it is a real kind of disorienting experience where all of a sudden you just feel this complete dread with no obvious source of it. Good news is, if you're able to kind of isolate yourself, take some nice deep breaths, you will get through it and come out on the other side. All right. And there's a whole category of anxiety related to fear of objects or situations. Now, fear of objects and situations can be very rational. It only becomes a phobia once you've reached this level of kind of extreme fear, or what would be an irrational fear. And so, for example, a fear of heights is very normal. Most people feel at least some degree of discomfort around heights. But it's when you have this kind of extreme physical reaction where you start having a panic attack as you get close to, or an anxiety attack as you start getting close to the edge of, for example, the Grand Canyon, or you look down from a tall building, etc. That's when it becomes sort of a phobia. And so it's characterized by that excessive and potentially paralyzing fear over something relatively non-threatening, right? So you can think about having phobias about anything in your day-to-day life, right? Maybe some of y'all have phobias over mice, for example. Mice are relatively unthreatening, non-threatening, and yet you can have this potential excessive and paralyzing fear when you see a mouse and freak out. There can be this experience of a serious sense of dread when that object or situation occurs, right? And so it's not just the projecting or thinking about whatever it is, but it's the actual experience of that situation or the environment in which that object exists. There is a complete inability to relax, right? And so again, when we think about the difference between a normal sensation and what would be characterized as a phobia, in a phobia, you are not able to calm yourself down, right? There's a certain level of anxiousness associated with, doing certain things, right? Maybe you're going out on a first date, you're going to be, you're a little anxious, but you can calm yourself down, right? Or you're going out to a public place and you're a little bit nervous. It's a new place, don't know what to expect. But it's not until you have kind of the inability to calm yourself down that it becomes this phobia. As with a lot of these other panic and anxiety disorders, you do have that trembling, sweating, racing heart, elevated blood pressure. And some people, in extreme cases, may even faint during a certain situation in which that phobia is triggered. Most common phobias, one would be claustrophobia, so the fear of tight, enclosed spaces. Acrophobia, so the fear of heights. I have a near paralyzing fear of heights. Every once in a while, I'll go watch these videos of, I don't even know what you call it, but it's like free urban climbing or something like that, where people will, stand on the corner of a building like this and jump off to a 180 and grab on with their fingertips and hang from their fingertips. And my palms are getting sweaty now, even just thinking about it. But the fear of heights is a real fear for a lot of people, and can be one of those things that is debilitating in everyday life. I can't get too close to a window in a really tall skyscraper because of that fear. Arachnophobia, fear of spiders. Spiders are inherently creepy and scare the living bejesus out of most people. And then social phobia, so fear of public speaking, fear of public embarrassment or humiliation. So again, this ties back to our nature as a really social creature, where ostracization, being ostracized from the community, in history could have been a death sentence, right? And so that's where I think a lot of this fear of public embarrassment comes from, right? You don't want to humiliate yourself, you don't want to embarrass yourself in a way that gets you kicked out of the group. More people are actually afraid of public speaking than they are of dying. And so you have this kind of situation wherein, even in classes, people who are normally very outgoing or effervescent in private conversations, once they get up in front of a class, really struggle with this public speaking aspect. I've known some friends from grad school who didn't go into academic positions largely because I think of this fear of public speaking and not wanting to talk to a class. And then finally, agoraphobia, so that fear of being in the open or fear of open spaces. All right, I'm going to pause for a second. Does anybody have any questions about what we've covered so far? All right, I'm not seeing any questions, but again, go ahead and finish typing them up if you do have any. Sorry about the puppies. I don't know what they're going on about. All right, so we talked a little bit about obsessive compulsive disorder and the distinction between the obsessions and the compulsions, right? So obsessions are these sort of recurrent anxiety-provoking thoughts or behaviors that are beyond your control, right? So the obsessions are things that you continuously ruminate on. Your thought process becomes overwhelmed. The compulsions, the compulsive side of OCD, is that irresistible urge to engage in the thoughts or behaviors with the idea that engaging them is going to reduce that anxiety, right? And so actually going home and checking the stove, like we talked about last time, giving into those sorts of ruminations, right? I think WebMD is one of the worst things for people's mental health, right? Because everything, every little ache or pain or sniffle or things like that can always be linked back to cancer if you're not careful, right? And so the compulsion of going and checking and continuing to look for information with the idea that it's going to reduce anxiety. And in reality, you're just kind of having this snowballing effect. Sorry, I'm gonna go deal with the dogs real quick. Hold tight. Sorry about that. Yeah, so those compulsions are those irresistible urges to engage in the thoughts and behaviors, right? Thinking about things or actually performing the actions of, touching the door handle in a specific way. with the idea that that's going to actually reduce the anxiety. It may temporarily reduce the anxiety, but it's going to make this kind of snowballing effect even worse, wherein you have essentially conditioned yourself to allow for these sorts of actions in an attempt to reduce the anxiety. The anxiety gets stronger next time, and each subsequent actual performing of the action has to become stronger in order to reduce that anxiety. So PTSD is something we see a lot in movies, usually tied to war and combat. And it is true that that's one of the major sources of PTSD for a lot of people. However, PTSD does not have to be in an actual combat situation. It's just that knowing, or excuse me, it's the response to an actual traumatic event, right? And so a lot of people who are survivors of assault will have some degree of PTSD. Those who may have been observed their parents in some sort of domestic dispute or domestic violence may also have issues with PTSD. And what actually is the marker of PTSD is that kind of knowing or unknowing revisiting of that traumatic event in the form of memories, dreams, or even full-blown flashbacks, right? And so one of the things you may see in movies is people having kind of these flashbacks, back to Vietnam or things like that, either in, while they are conscious and awake in the form of memories, or it could be while they're sleeping, right? These sort of night terrors associated with it. It could be the case that it's months or even years after the event where somebody develops these symptoms of PTSD, right? There can be a degree of repression of that, of distraction, and it's not until later that the actual symptoms arise. So this is not to suggest, when we talked about repressed memories, that you're repressing the memory. They still know the event happened, but the actual effect of that trauma hasn't necessarily been fully borne out for months or even potentially years. It can be really difficult to treat. That being said, there are a lot of great ways and some really creative ways in which it's being treated these days, including things like virtual reality immersion, right? And so when we talk about things like immersion therapy, wherein we put somebody in a situation and try to help them slowly develop a kind of calm response to whatever they're observing, whether it is with a phobia like heights or spiders or things like that. You can also have this kind of approach with PTSD, right? So we can put somebody in a very similar battlefield situation and teach them to kind of relax through it. Some of the symptoms here, that extreme anxiety and sleep issues, irritable outbursts, intense startle response. And so you may have had the case where you've heard of people who have come back from deployed environments. A cooler shuts really quickly, and they jump or lay flat on the ground thinking it was incoming mortar fire. My cousin told me a very similar story when he came back from downrange. And so it's learning to kind of cope with what happened, learn to process it in a way that doesn't evoke this kind of strong panicked response. And in fact, one of the things that the literature suggests are best ways to prevent PTSD now is to help people remain calm in a situation, right? During or immediately following a traumatic event, one of the most reasonable responses is kind of hysterics, right? It's overwhelming. People become hysterical. They become overwhelmed. Elevated heart rate, everything like that. But if you can actually, in these immediately following these traumatic events, help people kind of calm themselves down, catch their breath, slow their heart rate, slow their actual panic response to that traumatic event, you can actually decrease the likelihood that they develop these PTSD symptoms after the fact. There's also some evidence that giving people time to process it on their own before going in and talking about a traumatic event can help. Um, One of the things that therapists thought for the longest time would help is if you got in immediately and had people talk through what just happened. But what they found is that that actually increases the risk of developing PTSD symptoms, right? And so one of the theories behind why PTSD was less common in, for example, World War II is because when the soldiers came back from the deployed environment, they usually had 2 weeks to kind of decompress on the ship with other people who had been through similar things. And so there wasn't this process wherein they had to come back and talk about what had gone on and be isolated from those who had similar experiences. Um, and where they could really just kind of process trauma on their own before reassimilating back into life. And so getting people in a situation wherein they're not having to talk through these traumas immediately after the traumatic event can help reduce the instances of PTSD down the line. All right, next we're going to talk about dissociative disorders. So dissociative identity disorder was formerly called multiple personality disorder. And what's suggested by those who study dissociative identity disorder is that an individual has two or more personalities that don't exist at the same time, like they don't manifest themselves necessarily at the same time, but they exist within that individual, and that individual kind of slips between these different personalities. The personalities are frequently as different as you and I would be, right? So they have different traits, different memories, thoughts, and behaviors. And then the thought is that each identity may or may not be aware of others or the events experienced by other personalities, right? So if you're personality 1 right now and you experience something, personality 2 may not remember having experienced what you've already experienced. Now, with that said, there is substantial debate in the field about whether dissociative identity disorder is a real thing. It is an inherently, quote unquote, sexy topic of study, right? You'll see articles sometimes about, the woman who has 300 different personalities. The evidence is far from conclusive that this is an actual thing. Frequently, those who present with dissociative identity disorder are victims of trauma at other points, and so it becomes kind of a coping mechanism for them. But there's not really conclusive evidence to suggest that people do have kind of these different personalities that they would switch back and forth between. That's not to say that it doesn't exist, but the evidence is far from conclusive on that. All right, so I'm going to pause for a second and let y'all pop in any questions you have. Can y'all think of any movies you've watched? I didn't say anything, Liam. Can y'all think of any movies you've watched besides maybe what I have presented on screen, wherein characters have these different disorders? McKenna asks, assuming dissociative identity is real, can it ever go away? Yeah, so yeah, if it is a real thing, it would be kind of this break from reality, right? Much in the same way you would have a schizophrenic break. and so I don't know the means by which they treat it. I think that there are some anti-schizophrenic medications that may be used in these cases. Um, but um, I suspect the kind of main course of treatment for those presenting with dissociative identity disorder is helping to kind of treat the underlying trauma, right? So again, the suspicion is that it's trauma forcing somebody to kind of create this emotional and psychological distance. Um, and so I suspect that treating that underlying trauma may actually help in that situation. I haven't seen Split or Glass. I should probably watch all of those. Can dissociative identity form at any age or only early childhood? No, it can. My understanding is it can present at any age. I don't know of many cases wherein younger children are said to have dissociative identity disorder. I mean, there are cases. Most of those who I know tend to be adults. But yeah, I think it can form at potentially any age. Laura says, isn't a movie but total drama, Revenge of the Island. One of the characters, Mike, is shown as having multiple personalities. Huh, I'll have to check it out. United States of Tara, Tara the main character, Shutter Island. Man, y'all are giving me some good movie recommendations. Maybe that's what I'll do this weekend. I'll just pop onto Netflix and watch a whole bunch of these. Okay. What other questions do we have so far? Ashton asks, why was it renamed? I don't know the answer to that. This is far outside my area of expertise. It may have something to do with there being cases under this umbrella where it's not actually multiple personalities, right? There may be something about this dissociative split. So you don't maybe have another identity. You just don't think you are the person that you normally are. I don't know that. I mean, that's entirely speculation. It's also frequently the case that medical terms, or at least psychological terms, get relabeled after they've been somewhat, I guess, bastardized by popular culture, right? Once they have, kind of been used and developed this kind of colloquial meaning that could, in theory, carry stigma. So, I mean, think back to, for example, mental retardation, right? Despite that having at one point been the actual clinical label for people with severe intellectual disabilities, that's fallen out of favor because of kind of the co-opting of that word in a colloquial sense, and in the pejorative way it's kind of been used. And so I don't know the specific case, but if you figure out why or when they changed this, let me know. That's really interesting. It's a good question. All right. Give it another couple seconds here. If you have any questions, type them in there. We're going to go ahead and move on, but if you do have questions, but we've already covered, again, go ahead and hammer them into that group chat. All right, so now we're going to talk about somatoform disorders. So Somatoform disorders are disorders wherein you have nothing obviously physically wrong with you, but there may be kind of underlying psychological issues that are causing the experience of something physically wrong with you. And so one of these cases is what's known as a conversion disorder. And so an individual usually converts a source of stress into a physical difficulty, right? And so, um, this may manifest as somebody who has, um, extreme social anxiety, experiencing some sort of, for example, back pain anytime they have to go out in public, right? There's no obvious cause of that back pain, but they've kind of um, manifest a physical representation of their actual stress. Um, it can also be characterized by, I'm going to butcher this pronunciation here, but la belle indifference, which is just an apparent lack of concern shown by some patients towards their actual symptoms, right? So you could have cases wherein it's actually manifesting a physical sensation and just having patients not really care about that physical manifestation. Some of the more extreme cases can result in a total loss in physical functioning of a limb or a body part. Temporary paralysis in one's arm or leg, inability to walk, for example. But again, the important thing to note here is that there's no obvious underlying medical reason for this. And so there are certain cases wherein somebody who has like a conversion disorder, they may not be faking it, right? They may not be consciously aware that this is something that's happening purely from a psychological perspective. And so they may feel like they're telling the truth, but there's no obvious reason biomechanically for in this case, perhaps a loss of function in your arm. And so sometimes, and I think I even referenced this earlier in the semester, sometimes you may have to figure out ways in which to quote unquote treat that issue by essentially just administering a placebo, right? You have to give a person a reason to think that what you are administering to them is going to work to take care of that pain. I think there's even a House episode where House, I think, cuts somebody open and then just stitches them up, doesn't actually do anything to help treat their kind of conversion disorder, where they think they're having certain pain or certain inability to use a part of their body, for which, again, there is no known medical reason. So hypochondriacs are kind of, they're somewhat related to that conversion, except there's not necessarily an obvious case wherein they have a conversion of psychological stress into that physical representation. They may just become preoccupied with the idea that something is wrong with them, right? And so a hypochondriac is going to insist that they have a physical illness, but again, all medical signs point to no illness whatsoever. So they may become very preoccupied and concerned over minor details or sensation, which they proceed to exaggerate. So, you may feel a little twinge in your back, right? I mean, if you just take a second and think about your body, there are various kind of aches and pains throughout the day, regardless of whether or not there's anything major wrong. right? So a hypochondriac may say, oh my God, that shoulder must mean I've torn something. This is a really bad injury. I can't do anything. Um, they'll go seek help from doctors, frequently more than one doctor, because again, you're going to get doctors saying, no, there's nothing wrong with you. There's nothing physically wrong with you. And they're not going to like that response, and so they'll have to go to a variety of doctors. Now, there are other cases wherein there's no obvious physical indication of, for example, pain. There are some pain disorders wherein their brain is clearly processing pain when you look at it, but there's still no physical representation, or there's no physical cause that's obviously causing that pain. But a hypochondriac is taking little tiny things and essentially just blowing them out of proportion, right? So having little twinges in their knee, all of a sudden that becomes a really big reason to be concerned. A headache now means you have brain cancer, etc., right? So hypochondriac is really over the top on what can be really minor physical sensations. One of the difficulties in dealing with, for example, the opiate crisis is that hypochondriacs may come in and be indicating that they've got severe pain, be prescribed painkillers for things that they don't actually need painkillers for, and then become addicted to them, right? So again, another mark of this of a hypochondriac is going to a lot of different doctors until they're able to find somebody who kind of validates their experience and prescribes them, for example, medication to deal with their overall disorder. Any questions about those somatoform disorders? And somatoform disorders, again, would a placebo drug work in this case since the ache won't go away? Yeah, I mean, it very well could, right? So the only problem with it is if they're blowing kind of minor things out of proportion, they may latch on to something else, right? And so if it was my knee, now all of a sudden it's headaches or things like that. But you could, in theory, with kind of somatoform disorders, treat them with a placebo. Because what you don't want to be doing is introducing any sort of psychopharmacological, there we go, man, I struggle with that word, response when there's no real thing to treat, because you don't want to be throwing people's biology off. But if you can kind of give them the illusion that something is working, that would be great. Now, there are substantial ethical considerations at play when giving anybody any sort of placebo, right? Even in clinical trials, right? People have to know that there's a chance that they will be getting a placebo. And so a placebo is never going to be a long-term solution, right? I don't think doctors could just write a prescription for a placebo. But it could be a way to kind of help a patient understand that this is a somatoform disorder, right? And that there's kind of some underlying psychological issues that maybe we need to deal with rather than continuing to fixate on these physical sensations. It's a good question. All right, we will go ahead and push into mood disorders here. So major depressive disorder is a kind of severe, pervasive, persistent depression, right? So again, when we are making the comparison between normal and abnormal, it's normal for people to have bouts of depression, right? A lot of us at some point will go through a period of depression following some major life event. But a major depressive disorder is not necessarily tied to an actual event. I mean, it could be spurred by an event and people just are struggling to get out of that. But it is also frequently a kind of island in which the depression isn't tied to anything. It's just kind of this pervasive, real, deep experience. People with major depressive disorder have a lack of energy and poor concentration. They're going to sleep a staggering amount of time, right? I've known friends who have major depressive disorder who do sleep, um, you know, 12, 16 hours a day. Um, that's not always the case. But, there is kind of this overwhelming emotionality as well of the crying. It's also frequently comorbid with thoughts or attempts of suicide, poor appetite, again, severe agitation. So in a lot of these kind of cognitive disorders, one of the ways that people around the individual start to understand that there's something wrong is indications of agitation or lashing out. And then you'll also get instances of serious weight gain or loss, right? Substantial changes in somebody's actual body shape can be an indication that there is some sort of psychological issue at hand. Bipolar disorder is an instance in which we've got two different extremes, right? That's where the bipolar, the two poles, come from. It used to be referred to as manic depressive disorder, and those are the two poles that we are talking about here. Mania is kind of this extreme elation, very kind of irrational and illogical behaviors. People who are in kind of a manic state may go and spend way more money than they have. They may be over the top excited, lots of energy, very eager to be outgoing and do things, etc. And then following a manic episode would be a depressive episode, right? So you have this manic episode characterized by high energy and illogical behavior, etc. And then you have kind of this depressive backlash. There are two types of bipolar disorder. And so you have bipolar 1, which is characterized by very manic episodes. So these really high highs and depression. And then bipolar 2 is characterized by sort of a hypomania and depression. So you're still getting these kind of swings, but to a different degree in there. So again, like I said, during this manic phase or during mania, there's kind of this excessive, what you may think of as silliness. People are just goofy, lots of energy. Think of, your cousins or siblings, young cousins, who when they get really energetic, just kind of become way too loopy, right? That is a reasonable representation of what that actual mania would be. Things like carrying jokes too far, right? And so there are sometimes cases of celebrities who have bipolar disorder and during their manic phase are sometimes going way over the top with jokes that are inappropriate and put them in a really bad position. They can be very argumentative, have that poor judgment like I've talked about before, wherein you may be doing things that don't make sense from a logical perspective, right? You are spending excessive amounts of money. You are doing things that make no sense in terms of, agreeing to go do things that are illogical or making promises that wouldn't be logical for you to keep. There's also an indication somebody's kind of in a manic phase if they have really rapid speech and rapid flight of ideas, right? Higher than their kind of normal baseline operating tempo. And so, you can think of this again as kind of these almost stereotypical examples of somebody who is really kind of hyper, having that rapid speech, rapid flight of ideas. They're kind of all over the place. They're speaking really fast. They're getting really excited. There are some people that just speak fast inherently, but during these manic phases, it's kind of uncharacteristically rapid speech and rapid thought processes. During the depressive phase, it's very much kind of like what you would see with the depression in a major depressive disorder, having that incredible amount of sleepiness, lethargy. The people are socially withdrawn and very irritable. And so, what constitutes bipolar disorder are these major swings, or even less major, but still swings, substantial swings in personality that are not kind of within the frame of what would be a normal swing of emotion. Oh, yep. And during these depressive phase, you're still kind of carrying over any of the side effects that you would have within depression, including ruminations on suicide or attempts of suicide. So we showed that example of schizophrenia in last class, but it is kind of this break from reality. So disturbances in thinking, language, perception, motor behavior, social interaction. Um, what we showed last time was pretty indicative of the hallucinations and delusions that somebody may have, but you can also have characterizations of kind of nonsensical speech. So essentially speaking gibberish, or putting words together in a way that just it doesn't make logical sense, right? It doesn't, it's not grounded in reality in these sorts of way. There are also cases of delusions of grandeur, wherein they literally think they are God or the devil, right? So sometimes you will see people who are schizophrenic preaching as if they are a disciple, or they are God themselves, and or thinking that they are the devil, right? And they are meant to carry out evil acts. There is also kind of this this flip side to it, where you have essentially a lack of normal interactions, right? An emotionally void or flat demeanor, having kind of a blank face, a non-reactive face, like most people would have, and then also mutism, right? So they become completely locked in, they stop talking, everything is just occurring in their head. And there are a lot of great examples out there of schizophrenia. There are a lot of also really bad examples out there of schizophrenia, but I'm sure many of you have come across somebody who may be having a schizophrenic episode. And again, it'll be characterized by things that don't really make sense to an outside observer. Like they're talking to somebody else, or they're hearing somebody else talk that's not there. They're saying things that don't make sense. They are kind of talking about themselves as if they are all powerful, like God or the devil. And so we also have personality disorders. The paranoid personality disorder is kind of what you would think of stereotypically when you hear the word paranoid, of your belief that other people's behaviors or actions are inherently threatening or hostile. This isn't, sorry about the dogs. I don't know why they decided that now is the time to bark, but it's, beyond what people have of kind of just general mistrust or distrust of people until they get to know them, or different than when somebody has violated your trust. It is a real extreme mistrust. However, the difference between a paranoid personality disorder and schizophrenia is they don't have the same sort of disorganized thought as exists in schizophrenia, and they're not experiencing any of those hallucinations or delusions. So it really is a fixation on an extreme or overwhelming distrust of other people. Schizophrenics can have this sort of paranoia as well, but you can have the paranoia in isolation from schizophrenia. So again, it's not just the very reasonable lack of trust in an individual who may have violated your trust, but it's the assumption that every action that somebody takes is threatening or hostile to you. That's a good question, McKenna. McKenna asks, is it common for schizophrenics to have paranoid personality disorder, or is it just possible? There is kind of a classification of paranoid schizophrenics. I don't know what the comorbidity is for paranoia within schizophrenia. I know it is fairly common, but I don't know just how common. If you can figure that out, let me know, because that would be a good thing to know. But yeah, there is at least reasonably high comorbidity between schizophrenia and paranoia, but personality or paranoid personality disorder can exist in isolation from those sorts of delusions or hallucinations. Good question. There is also what we call borderline personality disorder. And so borderline personality disorder shows kind of extreme instability in relationships, self-image, and mood. Total lack of control over impulses, right? Very impulsive, very unstable. There is a complete lack of adherence to what we would normally deem as, or culturally deem as important of a young adult, right? Of having values, goals, loyalties, even fixating on a career and friends, etc. They also, when we talked about attachment several weeks ago, do not like having kind of this feeling of abandonment, right? They refuse to be alone. They have to be with other people. They have a very insecure attachment style. This is one of those disorders that tends to be very gendered. So a big majority of those who present with borderline personality disorder tend to be women. There is the flip side of that, which would be antisocial personality disorder, which we'll talk about in a second, which tends to be more men. But it is kind of this really unstable, unpredictable individual who does struggle to maintain any kind of fixation on anything other than themselves, if that makes sense. And we'll see how this is different than narcissistic personality disorder in just a second. So yeah, again, inherent in any sort of insecure attachment is going to be very clingy and demanding in friendships and relationships. Already talked about being unpredictable, can be self-destructive and self-undermining, right? They're doing things to throw a wrench in their close relationships. They're hurting other people. They are just completely myopic. They're very short-sighted in their day-to-day interactions. There can be a lot of suicidal ideation and attempts, but they are almost always for attention, right? So, one of the dangers with borderline personality disorder is that somebody with this disorder may perform an action in what appears to be an attempt at suicide. They have no actual intention of killing themselves, but they accidentally kill themselves just as a byproduct of kind of trying to reach out and get attention for this. You can also get the sort of self-mutilation as a mean of manipulating others, right? If you leave me, I will kill myself or I'll hurt myself, etc. And so, borderline personality is not something in which we are concerned primarily with people intentionally killing themselves, but it is an unfortunate byproduct wherein they accidentally complete suicide as a function of reaching out for this sort of attention. Narcissistic personality disorder is characterized by this sort of extreme focus on self, right? Extreme self-centeredness, arrogance, incredibly confident in their own intelligence, abilities, and their self. And it also manifests in kind of all that fixation on yourself is not at any point redirected to other people, right? There's no concern for other people, no empathy. In conversations with somebody who's narcissistic, it's all about them, them, them. They're not asking you about you. And narcissists are also very volatile if crossed, right? So somebody who is a narcissist with this complete confidence in self, if somebody brings up something about them that is maybe less than ideal or provides critique, they kind of act out. There's a backlash, a substantial backlash, because again, their idea is of their own excellence. Everybody else around them is an idiot. Anybody that crosses them is a direct threat to that individual, right? So in the same way that you may perceive a physical attack as being something that is actually dangerous to your well-being, somebody with narcissism is going to view a verbal attack or any sort of criticism as similarly damaging to them or to their safety. All right. Antisocial personality disorder, it used to be called sociopathic personality disorder. And so when you hear people talk about sociopathy, it is no longer really an actual diagnosable thing. But what was referred to as sociopathy is now housed in this sort of antisocial label. Those with antisocial personality disorder don't feel remorse or guilt for their actions. And so, this is frequently what a lot of serial killers can be diagnosed with, right? There's no guilt for somebody with antisocial personality disorder for hurting or killing somebody else, right? The guilt that you feel if you say something that hurts one of your friends or your loved ones is something that somebody with an antisocial personality disorder isn't going to feel. There's also this kind of complete, I'm not sure what you would call it, but there's an attempt to cover up and lie about everything or beg for forgiveness, right? It's not necessarily the case that somebody with antisocial personality disorder is going out and bragging about what they do. They, conduct whatever they're doing in a way that they try to get away with it. And if they're found out, they tend to try and manipulate those around them such that they're lying about things or they beg for forgiveness. And you see some of the early manifestations of antisocial personality disorder in childhood, wherein children are extremely aggressive in school or with siblings, right? Not just the normal roughhousing. Even bullying to some degree is kind of the normal pattern of development, but extreme aggressiveness, extreme willingness to harm people either physically or emotionally. You'll also see one of the kind of early predictors of those who wind up becoming, for example, murderers or serial killers, things like that, is an early fascination with destruction and death, right? So the actual harming of animals, the setting of fire to animals, a, a complete disregard for kind of the sadness associated with taking a life. But the extreme symptoms themselves tend not to manifest until somebody reaches about 40 or 50, right? So this is, again, not to keep going back to serial killers, but if you watch these documentaries, a lot of these serial killers are men in their 40s or 50s, because that is where you get this sort of extreme manifestation of that disorder. And so again, whereas borderline personality disorder is typically more common in women, antisocial personality disorder is substantially more common in men. All right. What questions do y'all have about today's lecture? Are people with antisocial personality disorder capable of love? Yeah, absolutely. So there are really interesting cases wherein people who seem kind of like these monsters are still, to some degree, operating normally in terms of their infatuation with certain people, right? And so there is a really interesting case study about a old mob hitman who killed a staggering number of people. I think the number was over 200 or something like that. A complete monster. Um, but by all accounts, he was absolutely infatuated with his daughters and with his wife, and was very much in love with them. And so it's not that they can't experience love. Now, I don't know to what degree they're experiencing love in a different way, but it's also typically more restricted in those cases, I think, than the normal experiences of love and compassion towards those around you. Good question. Are people born with personality disorders, or do they have to develop? That's a good question. I mean, as with everything, it's nature and nurture. There are genetic predispositions, right? And so sometimes you will see it passed along through somebody's um, children, but there are also, these environmental cases or environmental situations that can increase the likelihood that this is going to manifest, but can also help kind of guard against that actual manifestation. And depending on the disorder, you'll see different periods wherein um, it actually manifests. Like I don't think borderline personality disorder typically manifests until kind of like teenage years. There may be cases younger than that, but it typically doesn't manifest until teenage years. So it would seemingly be developed during the teenage years, but the underlying mechanisms which then manifest borderline personality disorder are probably there from birth. All right, well, that's all we have for today. Next time, we're going to talk about drugs and consciousness. And then a week from today, we're going to talk about human factors, which is my specialty. And that's how we will end the semester's lectures. I'm going to hang out here. If you have any questions, please let me know, and I will hang out until everybody has logged off. Otherwise, I will, quote unquote, see you on Tuesday. Have a good weekend.
going to ask, I have chronic regional pain syndrome, which is where I had psychological trauma and my brain convinced my body my leg was broken. Is that the conversion disorder? Um, without knowing everything about the situation, um, it could be a case wherein there is that sort of um, conversion. But this is so far out of my realm of expertise again that I want to be careful to not label any individual case as being that sort of conversion. Um, but yeah, I mean, based off of your labeling of kind of your brain convincing your body that your leg was broken, that would seemingly fit within that sort of conversion.